now invite the next panel members. Blood Lines and Fine Lines, The Art of Counseling in Hemoglobinopathies. Dr. Deepa and Dr. Madhvi are the moderators.
Gayatri, I think
again, good evening, everyone. I'm Dr. Deepa, and I are actually co-moderators here. So I'll be introducing the panelists today. We have a wonderful line of panelists with us. So we have Dr. Prantar Chakrabarti, Dr. Suman Jain, Dr. Janani, and Dr. Rahul. So just a brief introduction of the panelists today. Dr. Suman is a Chief Research Medical Officer and Secretary of Thalassemia Sickle Cell Society, Hyderabad. Dr. Prantar Chakrabarti is a renowned clinical hematologist, previously worked as a professor and head of Department of Hematology at NRS Medical College, Kolkata. And I do not know if Dr. Rahul has joined. Dr. Rahul is a pediatrician and a public health official in Kerala, very, very strongly associated with the National Health Mission for the public health initiatives toward which is specifically associated with the child health missions. And Dr. Janani, our colleague genetic counselor, she's the founder and scientific director of Aura Gene Private Limited and a postdoctoral fellow at IIT Madras and a scientist, a woman scientist specializing in women health issues and wellness. Okay, so going to the first panelist and your question, Dr. Prantar. So, sir, can you brief about screening and yeah, hello?
Yeah, I can hear you.
Yes, sir. Yes, sir. Yeah, sir. So, can you brief about the screening and confirmation of sickle cell diseases or generally hemoglobinopathies in general? And in our country, the public health ecosystem, what do you think are the strongest missed opportunities in the counseling for hemoglobinopathies?
Right. So thanks. I think I'll be as brief as possible. So you have to understand that when we are screening, that means we are looking at the healthy population. So if you look at sickle cell disease and thalassemia, there are certain pointers from the complete blood count. So complete blood count is an essential part of that, but the gold standard till now has been that hemoglobin HPLC, which is a high performance liquid chromatography. Now the problem is twofold. One is that it's not available everywhere. And second is that how do you make it cost effective? So there were certain other screening tests, like in thalassemia, we had a Nestrov test, naked eye, single tube, RBC osmotic fragility. But the problem is that it also confuses between iron deficiency anemia, which is also very prevalent. So it cannot be used as a gold standard. For sickle, you have the sickling test also, which done well can give you an idea, but again, HPLC is considered a gold standard. But in the last 10 years or so, we have certain other technologies which are calling themselves the point of care, which can help in screening. And in sickle, one advantage is, in thalassemia, the screening is mainly to prevent the birth of thalassemics. But in sickle, we also have an additional responsibility of newborn screening, because thalassemia newborn screening does not help that much. There is enough data on that. But in sickle, newborn screening helps us in administering penicillin, taking care of the initial complications. So newborn screening also with a point of care can help. What is coming, and we are seeing it, and slowly I think it will be deployed in a major way, is molecular techniques which can be for screening. So, you run a series of samples and you get it. We are trying to simplify it. Certain techniques are being validated, being piloted right now. But as we stand today, if you ask me that to confirm whatever you're seeing, even through point of care, it is in thalassemia, it is CBC plus HPLC. And in sickle, it is a point of care along with HPLC at this point of time. Yeah. Unless you're doing a molecular testing.
Molecular
testing. Now, yeah. Coming to your second question about India's public health ecosystem, strongest missed opportunities in early genetic counseling for hemoglobinopathies is not mass awareness. It is about when people are planning a pregnancy, right? And I think there has been some progress in getting the gynecologists and obstetricians aware. But I still feel we need to do a lot of effort. Foxy now has its own kind of things also, which they have partnered with us. But I think the miss is that we are still getting a lot of births. And another thing is for thalassemia, if you are screening during pregnancy, the intervention has to be early.
Early.
So if the pregnant mother is not coming during the first trimester, whatever technology you have, like prenatal diagnosis, is also a solution if screening reveals that both the parents are carriers, right? So what happens if both the parents are found to be carriers? Now you need to do it by 10 to 12 weeks. That also you need, predominantly it is still USG guided chorionic villus sampling, but we are also trying to build in certain non-invasive, fetal cells in maternal blood and all those things. But the most important thing is whether the persons who are planning to get a child, they know their carrier status. So, people, the next Gen Z, as we call it, they know their Insta status, Facebook status, but they don't know their career status. I think that is the strongest missed opportunity. So it has to be a targeted, mass-based, but depending on the density, the prevalence, especially as a public health specialist, I can tell you what works best is if you have a comprehensive prenatal testing so that you immediately get the result. You screen class 5 or 6 students, they may know their status by the time they're marrying, they're forgetting it. So these are my thoughts. I mean, they might sound controversial, but to do that, we need more and more people, communication, digital tools, so that this technology has been there for more than 30, 40 years. Maybe we will develop easier tools for point of care. But are people willing to do it at the right point? Are they willing to accept it? And they are not going to stigmatize it. These are the three questions I have for the entire community.
Thank you very much, sir. Very, very nice points. And I would take home one: awareness, awareness, awareness. So,
Yes.
and early, information as much we can give. So, thank you very much for your inputs. I think all the GCs are listening. So, let's go
Yeah.
to the second panelist. Dr. Deepa, are you there? I would like Dr.
Yeah,
Deepa to. Yeah, yes, Deepa. Yeah.
yeah. This question is to Dr. Suman Jain. You have worked since years on thalassemia and other hemoglobinopathies. So, based on your experience running a patient society, what are the most common misconceptions families have regarding these hemoglobinopathies, and how does counseling help to rectify them? Over to Suman ma'am.
Thank you so much, Deepa, for introducing me. And also, it is very important question. What are the misconceptions the patients have, families have? First, the challenge is these families they don't accept the diagnosis because sometimes this is the first child in their family who has been diagnosed with thalassemia or sickle cell disease. So, making them understand and accept this diagnosis is very, very important. Second, there is no acceptance what Pranthal sir has talked about awareness. There is no general awareness. We are talking about like we are only knowing what is thalassemia, what is sickle cell disease, but in grassroots level, in the community level, how many of them know about what is thalassemia? It is preventable genetic disorder. So this is a very important thing. The general awareness is required. How we have done awareness on polio vaccine, also HIV. So similar type of awareness is required because it is a preventable genetic single gene disorder. 3 to 4% of our population are affected with thalassemia carrier, and in some communities it is around 10 to 17% also. And sickle cell it is again 1 to 3 4%, and in some population in tribal communities it is going up to some 20% of their population are sickle cell carrier, and then once about the treatment also, they say think once that the diagnosis is done, they think the single transfusion will cure the disease. It is a lifelong treatment. They have to take blood transfusion, they have to take iron chelating drugs lifelong. So it is very difficult to make them understand Sometimes they don't come for 1 year and they come to us with 2 gram hemoglobin. So it becomes very difficult to, again, the counseling. So counselors have a bigger role in this disorders to be treated. And second, misunderstanding of the symptoms like sickle cell, they present with jaundice and all, but they think it has to be taken into herbal medicines and all these things because it is a yellowish discoloration of the skin. And sometimes they think home remedy, they go to so many people and all. They say, no, you don't have to go for blood transfusion and all. There is the treatment in Ayurveda and all things, and the patient will be cured. And then the social stigma. Many years back, they never used to disclose into their family members, that sometimes it has to be extended family screening has to be done, but it was not been done. Again, the lack of awareness about prevention. The second pregnancy, also the child is affected. So it is so difficult. So this is the first part. The second part, how the counseling support families, it definitely support, accept the diagnosis, adherence to the treatment, and sometimes the extended family screening. All this comes with the counseling. And third, what should be the second part, what should be the ideal model? So ideal model is what I sometimes feel the diagnosis, early diagnosis, what sir has already talked about. In thalassemia, we can't go early diagnosis because it has to be go for prenatal diagnosis or avoiding marriages between the carriers, premarital screening if we can be done. And second is it is the multidisciplinary team approach for the treatment. Counseling plus the other multidisciplinary, because the childs are surviving, they are going up to the 50 years, 60 years. So they are getting married. So gynecologist is required, pediatricians is required, hematologist, and the geneticist, counselors, and dedicated care coordinator to streamline the patient's management. And the curative care about the counseling. Now the bone marrow transplantation, every state has got the bone marrow transplantation unit and all. So children can get cured from thalassemia and sickle cell anemia, and the monitoring of this disorder, and outreach, and strong linkages with the PSCs and all. And antenatal screening is very, very important. That's why many people, they come for the diagnosis at the time of what I'm listening, like genetic testing, prenatal testing. So here also the antenatal, everybody wants a healthy child. So antenatal screening, when the mother finds to be carrier, the husband has to be screened, and both of them, if the carrier, then they have to go for mutational testing, DNA testing, and then followed by prenatal testing, and which gives a good result, and we have done antenatal screening in PSCs and all. Around 48,000 antenatal mothers we have screened, and we found a carrier rate of 2.9 to 3.1% in that PSCs, like in Mahabubnagar district and Medchal, Malkajgiri. So it is quite it is important, when this disease is preventable, why should not we prevent this disorder? It is quite possible, and the Cyprus has done it and all other countries. Thank you.
Thank you, ma'am. So the next question is to Dr. Janani. Dr. Janani, are you there?
Yeah, hi, ma'am.
Hi, Dr. Janani. Yes. So coming to, the genetic counseling point of view. So how can actually genetic counseling make a difference among families with hemoglobinopathies? And can you please share certain practical framework for discussing high-risk reproductive options where we have the prenatal diagnosis, partner testing, IVF with PGD in a very culturally sensitive settings? How do you go about it? Over to you, Jen.
Yeah, thank you, and thanks to ORDI and the team of genetic councils from BGCI who's taken efforts to put this series together. Much aware when aware genetic council awareness series is required. So coming to the question, definitely genetic counseling. My previous speaker, Dr. Suman ma'am, had just emphasized how much counseling is important for the families who have a child with a hemoglobinopathy. But and genetic counseling here can actually ease off the guilt, or from or in our society, or our cultural society, where women are easily blamed, that kind of sensitive thought process and guilt from the family is taken off, and they are educated on how this is being transferred to the generation. So it is not, it is not, one person is not blamed. And even sometimes the parents, they get a guilt that, is it me, is it because of me that the child is undergoing all of this? So these are really sensitive questions which they are put forward to me, when we see children, and this, the guilt behind it, even that can be eased off, and then they come to terms and to accept what is actually going on, and proceed with treating the child in hand. And definitely genetic counseling and a prenatal testing, like such as the IVF and a PGD, can prevent further children with hemoglobinopathies in that particular family and to the society also. So in this way, genetic counselors contribute a lot to the to the hemoglobinopathies community here. And since I've also touched upon IVF and PGD, definitely practicing genetic counseling in India, where it is cultural sensitive, not just cultural sensitive. So we have parents also coming around, taking decisions, interfering with the couple's decisions, and a lot of other things to be considered also when we're giving the counseling. So definitely the culture is very sensitive here when we talk such things. And so we have to slowly, with the education, slowly make them understand it is contributed by both the partners, and then, take a stand on the prenatal diagnosis. So they, before planning the next pregnancy, we educate them enough and to ensure that they return back to a genetic counselor, before planning the next pregnancy. Because they have one problem at hand, they have to take care of the child who is currently undergoing a treatment, and next pregnancy they will plan, but they shouldn't miss out, they shouldn't forget. And sometimes when you say the risk is 1 in 4 or something, they think out of 4 pregnancies, 1 pregnancy is going to be normal, and we have to educate. It's not like that. Every pregnancy has got a risk and all this. So such education will ensure that they are back to a genetic counselor when they're planning their next pregnancies. So partner testing becomes a lot more difficult because, like I said, in this culture or culture sensitive areas, women are easily blamed. The most vulnerable group is easily blamed over here, and women fall under that group. So it is a challenge on the genetic counselor to actually make the partner understand before they go undergo a testing. And IVF and PGD is definitely helpful for preventing further birth with hemoglobinopathies.
Thank you, Janani. So both families already with hemoglobinopathy and in prevention, both GCs can make a difference. Over to you, Dr. Deepa, for the next question. Do we know if Dr. Rahul has joined?
I think Dr. Rahul, I think he's head of NHM from Kerala. He hasn't joined. We will be winding up this panel discussion because hemoglobinopathies is a lot more to discuss. It itself can be an entire GC awareness in future. So thank you, panelists, and thank you, Dr. Madhvi, for backing me. Thank you, Dr. Suman, Dr. Pranthar, Dr. Janani. So
thank you, panelists. Thank you, Deepa.
Anytime
for you. Yeah. Thank you. Yeah. Take care. Okay, Deepanjana, I'm stopping my, yes, over to you, Deepanjana, and Nidhi for your, Nidhi is waiting. Yes, Nidhi, over to you, Nidhi, for the next panel. Okay, thank you. Yeah.
Thanks, Madhavi, and good evening, everybody. So we're going to have a quick change in the way we have been running the panel discussion so far. We have paucity of time, and so this is going to be a rapid fire round with all of my panelists. So genetic diagnosis of adult onset conditions has been on the rise, and the session today, Connecting the Dots, is to introspect a little bit about, are we working as together as a team? What are the gaps? And what can be done to fill those gaps? So please help me in welcoming my panelists today, Dr. Lohita Krishna, who is a consultant oncoplastic breast surgeon at Sri Shankara Cancer Hospital, Dr. Shagun Agarwal, who's a professor and head of Department of Medical Genetics, NIMS, and adjunct scientist, CDFD. My colleague and peer Neerja, who's a certified genetic counselor with over 10 years of work experience and is currently the Vice President Genetic Counseling at Map My Genome. And myself, Nibby, who will be serving as the moderator. So quickly moving into the first round, Dr. Shagun, the first question, when we talk about best practice protocols in managing adult onset inherited conditions, whether it is cardiac conditions, neuro, onco, what does that look like from a clinical genetics standpoint?
Thank you, Nibby, for that question. So, I mean, adult onset conditions come with their own set of, kind of complexities, I would say, because there are a lot of issues which revolve around these conditions. So, there are some kind of, the scientific or the technical issues with respect to that. Many of these conditions have a kind of an uncertainty associated with them in terms of whether they would be manifesting or not, at what age they would be manifesting, and also the degree of manifestation sometimes. So even in the same family, there can be a lot of variability in the manifestation itself, which causes a kind of uncertainty, and for the family as well as complexities in the counseling. And some other issues which revolve around these adult onset conditions are sometimes when there is just one affected member in the family, then I mean many families also have this phase of denial, because I mean typically the concept, I mean, or the thought process is that genetic diseases manifest at birth. So when you're telling somebody who's coming to you at let's say 40 years of age with the cancer, or I mean cancer still okay, would be adult onset, but somebody who's coming let's say with a neurological phenotype, and we're suddenly telling them that this is genetic and all. So very often families don't really kind of, it's difficult for them to digest, and it takes more effort to kind of keep it across to them. And yeah, I mean having another affected family member and all sometimes helps them get it into perspective. So and of course, I mean there are challenges also with respect to referral from clinicians for adult onset condition genetic testing, because I mean many of them we know don't have treatment. And then of course there are challenges associated with pre-symptomatic testing, when it should be done, and how those, it should be offered to a patient and a family. So I mean so we have to kind of often these are the set of conditions where we need to spend a little more time with families. So of course, as a geneticist, for us it's always a baseline that we will be making a 3 generation family history. We would be kind of really eliciting the smallest of points which give us clues about inheritance and all. And we do spend a lot of time with patients, talking to patients, which again helps them also the cross, I mean the ongoing conversations which happen with families often kind of helps them to kind of kind of guide them towards testing, interpretation of the results. And then comes sometimes the difficult part when a pre-symptomatic person tests positive for an adult onset condition. So how to prepare them for further their management or surveillance, or and of course the huge aspect is the psychological aspect of adjusting to a new kind of identity, that now I you have this condition, now how do I take this, how do I live after this. So I mean the basic concepts of genetics and counseling of course apply, but there are a unique set of challenges which come, so which again we have to kind of as per that family, that individual, we really have to at times spend more time, multiple sessions to for specifically for this category of conditions.
Sure, thanks, Dr. Shagun. And I think that's a great segue into the follow-up question that comes to Neerja as a genetic counselor. I think now we are seeing a lot of adults or individuals pre-symptomatically getting tested themselves or initiating testing themselves. So from your perspective, where does genetic counseling add the most value?
Thank you, Nidhi, for posting that question. And like what Dr. Shagun said, I think she's already reached a lot of these points. Just, having experience both in clinical front and being in the industry, on the lab side, we see that a lot of these patients are coming directly for testing. And oftentimes it's the wrong test that they're looking at. The first thing that you want to put a checkpoint is, are we even having the correct diagnosis in hand? Like, do we have a proper differential diagnosis? Do we have the right person? Is the right person even getting tested? And then, are we really doing the correct test? We've all seen cases where, it might have been a triplet repeat disease that we are suspecting, but then the testing was actually a full exome sequencing that was done. So I think clinically, firstly, identifying the right set of differentials, identifying the right person to test, and then identifying the right test that we should be doing. I think genetic counseling plays a very valuable role there to reduce any uncertainty. Ethically, we've all seen a lot of cases where either, there is a family member who's getting tested and you accidentally uncover the carrier status of someone who may have chosen not to know that information. So how do you handle that? Or if there is a partner who is, even we've seen cases where premarital screening, somebody's been pushing for their prospective partner to get tested based on the history. So do we really have consent? Is it ethical for us to push them for testing? Are they getting coerced? And then patient decision making. Once a lot of this is predictive testing, so there is a lot at stake. And in India again, I've personally handled cases where adults have been concerned about, how does this affect my insurance? How does it affect my job? How does it affect my decision for family making? So would I want to have children in the future? Can I be even capable of working, or will my employer, discriminate me based on these? So these are really important decisions, whether it's financial, social support, medical support, or then decisions about family that have to be thought through. So there's a lot of anticipatory guidance that will need to be done. And then there's been beautiful guidelines that are put together, whether it's from the Huntington Society, which, by the way, got updated in 2022 in case, we have not, somebody's not looked at it. The initial guidelines came in 94 and that has now been updated. And they still recommend doing at least 2 to 3 sessions before genetic testing is taken up for adult onset conditions. So these play a very important role in preparing that person who is undergoing the testing so they have the right tools in their hand when the report comes back.
Thanks, Neerja. Moving on to Dr. Lohita. Dr. Lohita, in oncology care specifically, I think this is one area where genetic counselors are actively involved currently. So according to you, where should genetic counseling ideally be placed into surgical and diagnostic workflows?
I think, yes, as you said, genetic counselors are very much involved nowadays. So I would say they have to be involved in multiple spots. I cannot put it exactly as a surgical or in a diagnostic way. I mean, we see patient for the first time, and in the first visit only, if we see those inclusion criteria, they have a positive family history. It is someone who is 40 years or younger, 45 years, very young patients, or someone who's just got a core biopsy, which is a triple negative breast carcinoma. Immediately, these are the candidates whom, or we're seeing a male breast. These are the candidates whom we immediately flag in saying that, no, these are candidates who require genetic testing. And as soon as we say that, I think it's very good to be integrated in the clinics, in the OPDs itself, where the patient doesn't just come to you and understand what a genetic test is and what happens in it, what if it comes positive, and all those questions, all the discussions can start. I understand that already they're going through this diagnosis in their mind, all this that's new to them, and taking in so much information, but definitely just touching upon it and talking to them on a first hand basis would really help. And then it moves on to the diagnostic workflows, whether they're going to give the sample for testing, and what if the test comes positive, is it going to change our treatment plan or the surgical plan, breast conservation versus a total mastectomy, then prophylactic surgeries, all the discussion comes in. And at the same time, including in the multidisciplinary tumor boards is also very much important, because suppose I've got a result and it says TP53 is positive, I do not want the patient to undergo post mastectomy radiation therapy, putting them to the risk. So in these situations also, when we have counselors there with us and involved with us, that also changes our treatment plan. So I think all these are three keys areas where it's very good to have.
Thank you, Dr. Lohita. And I think from this, it is clear that genetic counseling is absolutely necessary and an important part of the healthcare team working with adult onset conditions. Now, this brings us to the main point, like why are genetic counselors missing from where they should be there? So, Dr. Lohita, the first question goes to you. Do specialists sometimes miss out referral for genetic counseling because of genuine concerns? For example, delay in treatment or losing continuity with a patient or a family member who's come in. Your take on this?
Yes, so I think yes, we all understand and we know the criteria that okay, these are the set of people who require genetic counseling, who has to undergo genetic counseling. Then again, what happens? We are seeing patients in an OPD say for 15 minutes or to 20 minutes. In those time, we have to talk to them about the diagnosis, and what is the treatment plan going to be, everything. And it is upon us to emphasize to them also about the genetic counseling. How important is it that you go and meet the counselor now and not later? I think that is where we also take time to tell them, make them understand that, because the first thing they're going to ask is the same thing: how is it going to change our treatment protocols or treatment plans? So we have to make them understand about that, what is it going to happen, and the turnaround time of the report. So we want to go ahead with the treatment now. Today morning I'm going to tell them, you need to do a mammogram, you need to do this, you need to do that, and all the scans, everything. And then we'll have to tell them, wait for the genetic counselor, she's going to meet you at this time here and all. So that workflow, I think that's where a little bit of thing is there, where last thing happens. So we tell them, okay, fine, first cancer is important, let's get this one sorted, and then when you keep coming to the hospital, you can go through your and meet the genetic counseling team and all that. So we rarely wait for the report to come and then plan treatment. When we know that the plan is not going to change in a big way, we just go ahead with it and then finish all their treatments, and then they come in for prophylactic surgeries. But patients who are receiving neoadjuvant chemotherapy, we try to get the test by the time they complete their NSCTs, and then by the time they come for the surgeries, we're ready for prophylactic. So that's the main thing. I think availability, the amount of the processing that a patient can take it at that point of time, and things like that also majorly made. Loss of continuity, no. That also is there, definitely. But when it's an institutional practice, that the patient is in the institution and they are going to go and meet everyone. So I think that in institution is less. Yeah.
I love the point that you brought up about an institutional practice, Dr. Lohita, because like you said, when genetic counselors or genetic counseling specifically is a requirement at multiple points across a patient journey, there are different points where we are checking in and seeing, have they met a genetic counselor, or, what is a challenge, where is the delay? So thank you for bringing up that point. Dr. Shagun, my next question is to you. What do you see as the top reasons for this underutilization of genetic counselors, specifically maybe the area of direct-to-consumer testing, neurology, cardiology, etc.? So your take on that?
Okay. So, I mean, I would say one of the things, I mean, first, I mean, just to continue from what Dr. Lohita said. So, I mean, sometimes, I mean, at least in the setting of a cancer, it's, kind of too much for the patient to take, both psychologically and at times financially also, when they're already undergoing treatment, they're planning. So, I mean, they're doing so many things, the whole of their life gets disrupted literally. And then on top of that, we add another test. And I mean, so sometimes, I mean, that is one of the things which again, I mean, causes it's kind of a barrier to going for counseling or testing. But I would say there is another issue which is kind of again common to all these conditions, I would say, which is that the concept of a preventive health, or kind of having a practicing medicine not just for therapy but for prevention as such is not really part of our system, frankly. All our health systems focus on treating, and like, even for cancer, as Dr. Lohita was saying, that okay, how does it impact my treatment at this point of time? But then, we the thought process, I mean, for us as a whole, at the medical system, for the patients also, of that we can prevent certain things. And that's where again genetics, and in this context, of course, the role of the counselor comes in the sense that for all these kind of adult conditions, for certain conditions, let's say hereditary cancers, or for cardiac conditions, or for things like autosomal dominant polycystic kidney disease. So if we make a pre-symptomatic diagnosis, we can actually improve the health outcome of that individual, and not just that individual but the whole family. Because once one individual is diagnosed with a particular genetic condition, most of these adult onset conditions are autosomal dominant, they run in generations. So you are literally looking at a whole family whose future also you can change, and not just the patient in front of you. So that's where kind of the testing, the counseling has a very important role to play, whereby you are really holistically helping not just this person but the whole family, and not only helping in terms of today's aspect, but a time, I mean, what can be done today, but as a a life, as how you can impact his life and his health, over a period of time. So that is what kind of is that concept, or the thought process itself is missing from our systems, our training and all. So I think that is one of the kind of major barrier which I feel, which also prevents referrals, prevents patients taking up testing, or patients coming back for reviews, follow ups. So even if tomorrow you give a patient a genetic report, let's say for a hereditary cancer, I mean, despite telling them regarding surveillance, many of them don't really go for it, in as per protocols, because of the same reason. So I think that itself is one thing which has to somewhere get incorporated in the training aspect, and I mean, as a whole, of course, as a society or as a country, as a thought process. So I think that is one thing which I feel very much is one of the major things which we see. But of course there are other issues with respect to we don't have enough genetic counselors as such. We don't have positions for counselors, and we don't, I mean, and most of the the genetic workforce, be it as geneticists or counselors, are based in the bigger cities or the bigger centers, whereas we are not able to reach actually a huge majority of our population. So I would say there are multiple challenges at all levels actually which we need to overcome.
Thanks, Dr. Shagun. I love that you brought in the point of preventive versus reactive practice. And I think that's something that we, especially when we are looking into adult onset conditions, that's something that we need to keep in mind. Now, I will wrap up with this one question. I had another set of questions, but just this one question to all three of my panelists. If you could implement one change tomorrow to improve integration of genetic counseling in management of adult onset conditions, what would it be?
Yeah, if I can take this first. So I want my genetic counselor just in the right room next to me all the time that I am seeing my OPD. I think because that that one stop thing happens. One stop, you see, you do counsel, test, and go. So I think that's my one
That
very quick answer to that. Yeah.
That's just perfect, Dr. Lota, because I was just about to say that, at least to everyone who's listening, I mean, anyone who's at a position where you refer a patient for an adult onset testing, or a person, if they want to refer themselves, self-refer themselves for genetic testing, please consider coming in at least for a pre-test counseling. Whether you go ahead with testing, however you do it, with whichever lab you do it, doesn't matter. Just come in for a pre-test appointment, or at least for all the clinicians, make an offer. Whether the patient takes it up or not is a separate thing. I think right now the biggest issue is that we're not offering enough, because whenever they actually walk in, then there's this snowball effect that happens, and there's so many other things that follows through. But let's first start with making the offer to them, to give them the option to, okay, here, go see a genetic expert, figure out whether this is something you really want to do, and then proceed with it.
Yeah, so I mean, I don't think I have much to add to that, except that, I would like to kind of, at my level, talk to, other specialities. That's where I think that, where I mean, in the way the change would come, whereby, we can have one-to-one conversations with other specialties, because literally there's no specialty of medicine in today's date which is untouched by, genetics and which doesn't have a component whereby a patient requires a testing and counseling. So, for me, it is more, that we really need to reach each and every specialty. So, one-to-one conversations, kind of interdepartmental, multi-departmental discussions, case discussions, and also, sometime in future, there's something similar to what Dr. Lohita said. We should have special clinics where we could have, individuals from different specialty who are involved in care of a particular patient, as a kind, a particular kind of cases. We should all sit together and have a kind of a group, kind of a group, whatever you say, consult with the patient, and this team should consist of a genetic counselor. So that's what I feel. Should be what we should be looking at in future. But then, of course, we have to move one step at a time. So let's hope we get there. Yeah.
Thank you, Dr. Shagun, Dr. Lohita, and Neja.
Thank you. Thank you
We're
so
all on the
much.
same page, and I think all of the points that we discussed today are great starting points for all of the stakeholders involved and anyone who really is watching this and listening, whether it's patient support groups, whether it's genetic counselors or specialists, and like various boards that we have in the country. So I'll quickly summarize our segment and what I felt was crucial as a takeaway. First, very clear that genetic counseling is not optional. It is essential to safe, ethical, and patient-centered care, especially when we talk about adult-onset conditions. The gaps in availability of genetic counseling is structural, so more awareness, referral pathways, workforce shortages, all of this play a role in the gap that we see. And last but not the least, integration of genetic counseling services must be intentional. Embedding genetic counselors in multidisciplinary clinics, tumor boards, EHR-driven pathways is what is required to move from reactive care to preventive care. So with that, thank you so much to all three of my panelists and ORDI for having us here. Over to you, Dipanjana.
Thank you so much. And thank you everyone. And I'm really sorry for the time. And otherwise, we just ran 15 minutes offshoot. I would now request Dr. Aparna Dhar, ma'am, to please come up and introduce her panelists.
Good evening, everybody. I'm guessing my panelists are here, Dr. Shifali, Dr. Charu, and Dr. Kanika. So I think what a brilliant way to end the session by, one of the last ones that we have is that who invited the genetic counselor? But I think it's in modern oncology today, it's more about how on earth did we run a tumor board without a genetic counselor? I think we need to use that a little bit. And I've got with me a powerhouse of women today. And they are going to help drive this point home. We all work together. So I've got Dr. Kanika Batra Modi. She's going to represent the surgeon. She leads our gyne-onco team at the gyne-onco program at Max Healthcare. Then we've got representing the medical oncologist, Dr. Shifali Sardana. She leads our GI and our gyne team. And then we've got Dr. Charu, who's representing our radiation oncologist, another institution on her own. And she's going to be representing radiation, and she heads our gynec and breast DMG. So very, very quickly, let's start with you, Dr. Shifali, because I know everybody's ready to finish. So let's start with you, Dr. Shifali.
Yeah.
You feel having a genetic counselor actually made a difference to your clinical practice?
Perfect. I think if I talk of the personal life, I have Dr. Parnadhar making a difference in my life. And if I talk of professional, of course, everything apart. So very important nowadays. So we are now dealing with the precision oncology part. And if we talk not of precision oncology while discussing with the patients, I think it's unethical. And moreover, patients are well read. They have right to understand what all genetics is all about and what are the kind of therapies available. So of course, we need a trained expert for that purpose. And there comes the role of genetic counselor. There comes the role of the molecular oncologist. Whatever we name, we need that expertise. So I think if you want me to recall a case, I think that's the important one is where the testing and counseling for MMR and MSI made a difference in patients' life. You know, the young patients, they are afraid of getting chemotherapies. If we talk about GI cancers, where I do specialize. So it's very hard to convince patients about, say, the kind of APR surgeries which are very morbid and the kind of neoadjuvant chemos in CA rectum. And if you tend to get a MSI high, I think this is icing on the cake. So, because you know that immunotherapy will work well, you have all data available. But apart for that clinical data, you need to understand with the psychology of the patient how it impacts testing a MMR. It's not only the giving of immunotherapy, but it's whole lot of testing for Lynch and every other probability. So I think that is where a genetic counselor or a molecular oncologist expert's input would make a difference in our lives. Thank you.
Perfect. Thank you. So let's move on to Dr. Kanika. Do you feel somewhere genetic testing has made, or having a genetic counselor on board, can you think of something where it could have changed your practice as a surgeon?
Yeah, hi, good evening. Thank you, Aparna. And I'm so sorry I cannot put my video on. So yeah, I would give you an example from surgical side. So we had this, one patient who was a 38-year-old lady who had endometrial cancer. So although she was a grade 1, stage 1, you know, and she was keen on having a second pregnancy as well. So we did her biopsy and we wanted to, put her on a fertility sparing thing. We wanted to put her on progesterones because she wanted to have baby. So one of the criterias that we have is to do a proper molecular testing on it. And on that routine IHC, we found a loss of MSH2 and 6. So then she underwent a germline testing on the basis of that. And on the basis of NGS, we found out that she had a pathogenic mutation for Lynch syndrome, the MSH2 one. So this immediately changes her risk profile of, not just endometrial cancer, which she was diagnosed with, but with ovarian cancer risk also, and further on colorectal and as well. And she realized that there are future cancers and not just the present cancer, and which is of a significant concern. So it changed our plan, firstly, of offering her a conservative management. That was not a possibility. So we told her that there is a chance of high risk of a metachronous ovarian and colorectal cancer as well. And then we did a surgery for her, which included a total hysterectomy and a bilateral salpingo-oophorectomy, along with sentinel lymph node mapping. And we initiated her colorectal surveillance as well. And she had one child already, a daughter, who would also undergo further testing when she turns 18. So, this way she avoids the risks that she has and a future ovarian cancer risk that could have been missed otherwise. So this is how it really demonstrates we need to do a proper workup, molecular and genetic, before we go on to our scalpel. And a simple IHC panel changed everything for her.
So I'm just going to ask you one more question because I have paucity of time, so I'm going to try and put everything together. So, Dr. Kanika, do you feel that when we do this genetic testing, they should be done at a particular time? Like, would you like this information before you make a treatment? Or sometimes it's, okay, let's cure, and then we'll see later on what to do with the genetic testing. Do you think that makes a difference that, like you gave this example, but do you really feel that if the genetic testing is upfront, it's easier on the patient, or we can treat and then figure it out later? What would you recommend?
If I am to just, summarize in one line, my case, it proves that genetics today is not just for academic purposes, it is a surgical thing as well. We changed our entire plan depending upon the report that we had.
Thank you. All right. So, Dr. Charu, we do know somewhere radiation and genetics. I think the love affair started first with radiation, and genetics started way back before the surgical medical people came on board. In your clinical practice, can you think of an area where we've actually brought in, having a geneticist on board, a genetic counselor, and how genetic testing has changed the way you practice in your clinic?
Yeah. Thank you, Dr. Aparna. And, and thank you to the organizers for having me here. And if I can recall, Aparna, it was 2013 when the famous the Angela Jolie effect came in, and that was the time when the world was taken by storm, and we had so many curious coming in, and almost every year 2 or 3 women would land up in the clinics asking for getting a mastectomy done on, and at times they were not even BRCA positive. And as we were discussing in the earlier this thing also panels, that it is very essential to have a genetic counselor on board, especially if we are in a setup where we practice majorly oncology, and especially with all these cancers what we have talked about, the breast, gynae, GI. So I mean, if I can recall, so there was this 78-year-old lady who had undergone BCS, a breast conservation surgery for a T1 tumor. And there was, so that, I mean, that till the time she underwent her surgery, we didn't have the genetic test with us. And by the time she reached me, we realized that she had a TP53 positive, and that is when I called you up and you said send back the patient to me, and you discovered that she had a Lee Frommeny syndrome. And then we counseled the patient, and the patient went back and forth a couple of times, and we realized that her, as such, we could have foregone radiation with her because she was a very early stage, and we could have just put her on hormonal therapy, and that is what we did for her. And on your recommendation, she's been on a whole body MRI, colonoscopy, and every 6 monthly alternate MRI and of the breast and mammography. So I think genetic counseling is something which is very important in this era. And now every time, I mean, the patients who come to us, and somehow if the family history has been missed, so immediately I think that is the time when we tell the patient to go to you and talk. And I think the other thing which is very important is the pre-genetic counseling. I think that is very important because I mean, even if ordering a test is okay, but then I mean, at times patients may turn around and say we never wanted to know about it. So I think I tell all my patients to please go have a word with the genetic counselor, understand what does the pre-genetic counseling entails, and are they ready to hear what you're going to tell them. So I think the where we are moving, the genetic counselors would be probably the first one whom the patients would be visiting.
No, that's amazing. And I can vouch for it that these guys do it. They do send it to the genetics clinic before they make clinical decisions. So, Dr. Chowra, I just want to ask one more question. So we know, like, one is TP53 Lee Frommeny, very well established, but we also know with certain other genes, like your ATM in a heterozygous state, or, ATM in homozygous is where radiation is contraindicated, or sometimes MMR testing. If it's on tissue, somatic, we do know that the patients respond better, especially in your GI malignancies, whereas if it's germline, they don't respond that well, or they actually have higher radiation toxicity. So when you look at a genetics report, are you also factoring in this aspect of radiation toxicity? Like, is that something that you'll be looking at?
Yeah. So, I mean, you were asking, I think there was a question, when should these genetic tests be done? So, I think they have to be done upfront because it changes the treatment, like what Dr. Kanika just said. Similarly, I think the ATM gene is something where homozygous, we really don't want to give radiation. And heterozygous is okay. We expect that there would be some increased radiation reactions, but we still go ahead and do it if the pros are more than the cons. And the same goes for the MMR.
Right. No, perfect. So I think what we're hearing from all our speakers is that, genetic testing, be it upfront, is what is recommended, obviously, with pre-test, and it does change treatment outcomes. Now, I want to actually, while we're talking about the positives, there are gaps that are there. And I think one of the key gaps is when we look at our molecular tumor boards, when we just look at our clinical settings. What can you think of in your practice in particular? This is, let's say, before I joined, but what would you technically say is one of the, one of the challenges that we all face in our clinical setup in an Indian context when you don't have access to a geneticist or genetic counselor? And how can we actually kind of beat that? So let's start with either one of you. Dr. Shefali, do you want to start?
Yeah. So interesting questions, actually. And we do face challenges So if I think about the patient perspective, adding one more clinical input into the ongoing scenario after the breaking of news sometimes poses a challenge to convince the patient, okay, why this is important. And if we think about the treatment perspective, because see, whole of the system, especially in India, in our setting, is not designed to have the clinical inputs or the genetics input as a regular scenario. So now we are evolving and we are also learning that, okay, this is the importance of the genetic testing, the counseling, the sessions which patient should have to make up his or her own informed decisions. So I think giving the patient that perspective, and which one institute gives and another does not. So it has a gap and question in the mind of patient. So, but having said that, it is our responsibility also to make them aware about this perspective of the treatment part so that they have their pathway forward very, very clear in front of them that, okay, this is uh, another factor which is contributing to the treatment, which is contributing to the risk of recurrence, which is contributing to the familial inheritance also at times. So that is why I think to fill that gap, it is our responsibility to make them aware, to counsel them regularly, and making the genetics clinic a regular part of the patient visit in all patient scenarios. And having said that, the molecular tumor boards over and above that, and that is very essential part of the treatment. Yeah, thank you.
Thank you. So I think one of the key takeaways is if you show the importance of having a genetics clinic, there is demand for it, and then automatically other institutions and everybody will start imbibing it. And obviously having trained genetic counselors goes without saying. Dr. Kanika, would you like to add to that? Is there anything you feel?
Yeah, I mean, it is obviously an essential thing. And, at different institutes, we do have various gaps. And one way to fill it is obviously train more, youngsters as genetic counselors. And as a surgeon, I can tell you the number of conversations Dr. Aparna has with our patients. She just preps them up for a prophylactic surgery, and I just have to do the technical job. So it saves a lot of my time and surgeons actually, because these conversations, they don't happen overnight. I think Dr. Aparna can probably tell you more back and forth, the kind of things that come out. It's a huge thing. It's a huge burden that they're carrying in their heads, and there are too many layers that are unraveled while a genetic counseling is done. So it our job as a surgeon becomes much more easier to do technical job. And if Dr. Aparna has seen our patients, they're thoroughly convinced when they need the surgery, why they need it. So yeah.
Thank you. Dr. Charu, would you like to add to that?
I think cost is another thing. And I don't know whether, are these tests reimbursable or not when you order these NGS? Are
Some
they
panels.
reimbursed?
Some of them are with some insurance providers. Sometimes they are, sometimes they aren't. It depends on the patient's insurance.
Because I think cost is another big issue. Asking for these tests and, explaining the reports as well, which you do wonderfully.
Thank you. This was more about, this suddenly seems like the Aparna show, but no, but I think what we're all hearing is that one thing I want to highlight is while we all are putting these points across that, this is the lacuna in the system, and the reason that we're able to do what we do, and I can speak from experience of what we do in our clinics, it's because it's a joint effort. So I can have a conversation with my patient, talk about prophylactic, but I can only do that when the surgeon and I are having a conversation and we understand that prophylactic is important, or we understand that immunotherapy is required. So that requires Dr. Shefali and me actually having a conversation and understanding why is it required. Or with Dr. Charu and saying that, look, we're not going to be doing radiation, or we've done somatic testing. We've picked up this mutation, XRCC2. We know this is somewhere where radiation, the tumor is radiosensitive. So we're kind of primed and saying, okay, let's do radiation. And all of this actually comes working in silos. So for me, when I look at it, one of the key gaps is that a lot of us don't work in tandem with one another. We're all working in our own silos. And what's actually changed over here, and I feel that, you know, the reason we're saying what we're saying is because we all work as a very cohesive, comprehensive unit where everybody's role is important. So we all understand that this is what someone has to do and we work together. And I think Dr. Shefali, you wanted to add something. I just saw you raise your hand.
Yeah. So you made a very good point, Dr. Aparna. I just was recalling that the conversation before meeting the patient between two of us, or between you and Dr. Kanika, or between you and Dr. Charu, makes a difference. Because sometimes we give you the input, okay, we are giving this therapy, it is working well. So should we change or should we not? Or should we wait for the time to happen? So I think that conversation is very important, because patient has a lot of anxiety. Be it the treatment part or be it the other perspective. So it's our job to help them out in that treatment understanding also. So a conversation between we as a team is very important before we present it to the patient. That is a very good point you made. Yeah.
Yeah, so I think that cohesive thing. And just to very quickly put it over here, I think these are the key clinical values. I think that the key values as genetic counselors we do bring to a tumor board, to clinical practice. So I know that a lot of GCs are hearing us. So there is a lot of clinical value. Guess what? You know how to read, you know which is the correct test, you know how to interpret this report. You have the unique ability of actually reading and understanding the molecular pathways. So one is clinical value. It's about family testing. And most importantly is in a multidisciplinary team. You know, your voices are going to be heard, but you have to also be vocal. And most importantly of all, please befriend the teams that you work with. That makes it much, much more easier for you to integrate within the system. So very quickly, Dr. Shefali, one word of advice that you want to leave for our genetic counselors.
So I think my advice would be, like, we are evolving and we have to evolve to adapt the genetics clinic as a regular part of our system. And once we are going to adapt, the whole of the system is going to adapt accordingly. So it is very important that we should be aware. That is how we will make our patients aware.
Thank you. Awareness. Dr. Charu, one nugget of wisdom.
I think the genetic counselors have to be a part of all the multidisciplinary tumor boards, and even the site wise DMGs, what we do. Because, you know, I think you people are there in all the sites, at all sites, you guys are there. So you have to be a very integral part of our tumor boards.
And Dr. Kanika, your key takeaway, your words of wisdom. Have we lost Dr. Kanika? I know she's in between OTs. That's why
Yeah, sorry.
No?
So one piece of advice, as a surgeon, I would definitely say so. With respect to another case that we are going through, she's been referred to me for abnormal bleeding, and I took her hysterectomy. She had this really huge family history. On top of that, she had one genetic test that said that there is no mutation, nothing that is there. I still referred her to Dr. Aparna, and through the whole thing, she's getting some stuff from another institute. I find a VUS now. So I had to make a decision of whether the ovaries need to be taken out in her or no. So I think it's such an important decision for a woman who's 45 years old, whether her ovaries need to be taken out or no. So it's not just about ordering a test, it's ordering the right kind of genetic test and interpretation that needs to be done by a person who knows how to do it. The clinical suspicion needs to be really high before we miss out on things.
I think one of the key takeaways, because I think your line broke in between, Dr. Kanika, is the fact of clinical correlation when we are interpreting the reports. And yes, the onus does fall on the genetic counselor. I think, if we want to be part of the team, a lot of responsibility also comes on to us. So, and also your surgeons are going to be depending on you, radiation, medical oncologists. So do not think that, it's on them. The onus falls on you. So I very quickly want to just close by saying, I think the very, very simple truth is that oncology is no longer just clinical. We know it's molecular. And a tumor board without a GC is actually a map without a compass. You can still move, but you may not be moving necessarily in the right direction. And most importantly of all, none of this happens in isolation. I think precision oncology definitely and must remain deeply collaborative. And what you saw today is the collaboration that we all have within our ecosystem. So I'm very lucky and very grateful that I get to work with such phenomenal individuals. You've got to see few of our very dynamic women that I get to work with, but we do work in a team that's very, very cohesive and, very integrative of each other. So I do think that tumor boards, we're not guests in the molecular tumor board. We're definitely the secret sauce that makes precision oncology work. So on that note, thank you so much to my panelists for joining us and sharing their insights. And thank you, Dr. Dipanjana, for having me here today. Over to you.
Thank you so much, Dr. Aparna, and such a beautiful session. I was awed as usual by whatever you say. I loved that word you said, that a map without a compass. And I guess that's exactly where we are. And if all my fellow GCs are here, the moderators are here, the experts are here. Once again, extremely grateful to all of you and really thankful to all of you. All the panelists, the clinicians who at the busy hour actually spent that 20 minutes, 15 minutes with us, and all of them giving us insights. A heartfelt thank you to Prasanna sir and Organization of Rare Disease India for giving us the platform. And one last year for all of the GCs, the moderators, and also the GCs who actually joined in. We at one point had at least 85 people who joined in, and that was phenomenal. And really, one thing that our GC community, we do tend to uplift each other. We do tend to work with each other. And our community, GC community as a whole, is quite cohesive. I'm also grateful to this particular thing that, if I ask my friends and my fellow GCs to host something even 5 days ahead, they get into the madness and they actually jump in with me. And thank you so much for that. So with that, we know it has been a mini CME with wonderful questions and wonderful insights. I thank everyone who joined in, the panelists, the moderators, the delegates who joined in. And we hope to do this more often, raise such questions. And with that, we also make a reminder that Rare Info series keeps on happening. It's a weekly thing. Please look into the page. And with that, a very good night to all of you. Thank you. If every one of you wants to say one word, because I see people are here, so everyone can say one word. We'll start with Neerja and then come back to Aparna.
I think, firstly, I think each of the speakers, panelists, moderators, you guys are great, and thank you for putting up this show. But for the big thank goes to Dipanjana, who has, started this initiative, inspired all of us, and of course took all of us along. So thank you, Dipanjana, for providing and also curating this entire thing in such a short span of time, and ORDI specifically for giving us the space to be able to do this. I think we should do this more often.
Yeah, Gayatri, please.
Thank you, Dipanjana, and all fellow GCs for putting this together. It was a wonderful session, and thank you for ORDI for giving us this platform. We hope to have similar ones in the coming weeks where we could have focused discussion on each of these. It was a very wonderful start to a session where we had all these specialities together. Maybe we would have more focused in the future.
Yes, it's a wonderful primer which we can probably develop more and have more time to discuss what we were discussing in detail. Can I have Nibbi, please?
Hi, thanks, Dipanjana, and of course, ORDI. I love the entire discussion. I love how cohesive the ideas just flew, and there are like action items for each of us. And like I said, for anybody who wants to do something in raising awareness, in hiring genetic counselors, in learning about genetic counseling, I think this is like that one step to understand what we do as a community. So this was fantastic. I really loved it. So thank you.
Same here, and right love back at you. Is Deepa or Madhvi, anyone from the hemoglobinopathies panel there? I can't see Deepa actually, but Madhvi, you are there, right?
Yes, Deepa, I'm here. Yes. So for me, I would personally say I'm very, very happy to see all of your faces smiling, listening to your voices. I know across the country, everybody's doing wonderful jobs, sharing everything. So that was the beauty, the whole thing here, not the content. I'm like, okay, every session I'm looking at you people listening. So it was a wonderful 2 hour. Okay, so awesome,
Thank you
really
so
great.
much.
Yeah.
Yes. And is Aparna still around or she got busy, I guess? I think she left. All right. Thank you so much, everyone, for the short notice. And with that, good night and have a great evening. Bye.